So, Dr. Crawford, as we continue our conversation today, we want to talk about therapeutic hypothermia. I know that a lot of the research is showing pre-hospital is not a whole lot of benefit, but this is kind of a personal thing for me as well, because my daughter's father-in-law suffered an arrest, which we resuscitated, and then spent a few days in therapeutic hypothermia. And short of not remembering the event itself, he doesn't have any deficits. So we just wanted to get some input.
Yeah, I think that the therapeutic hypothermia treatment and concept has been around for several years. It's somewhat controversial, as you mentioned, in the pre-hospital arena. Now, that hasn't always been the case. Several years ago, many of the services were actually instituting therapeutic hypothermia in the field, either through the chill core devices that basically chilled fluids, and we were given 2 liters of chilled normal saline. There were ice packs applied, anything that sort of started to lower that temperature.
Sure.
And the whole purpose of it was to sort of get those patients to 32 degrees Celsius fairly quickly. And the science behind that was that, although it was multifactorial and that there were many things that they thought that cooling would do. But the biggest thing is it reduced brain metabolic activity, and also it would it reduced the amount of a excitotoxic metabolites in the brain. There's good research and good data now that supports therapeutic hypothermia in the hospital setting. There's not very good data that supports that in the pre-hospital arena. One, I think that it's very difficult to adequately monitor that temperature in the pre-hospital and reliably cool these patients in the field. And there's some studies that are coming out that says that chilled normal saline, you're bolusing with this liter or 2 liters of normal saline in the field that's been chilled, that there is an increased risk of rearresting. And also, as many people were concerned from the very beginning, was that it would lead these people, in that pathway down into pulmonary edema. That heart's shocked anyway. Heart's not pumping very well, and then you're giving them, 2 liters of normal saline, whether it be chilled or not, you're increasing their risk of pulmonary edema. Sort of the current concept now is more of a targeted temperature management that some people are using. Again, therapeutic hypothermia is still a very accepted practice in the hospital setting, but again, they're cooling these people with reliable cooling mechanisms, with a protocol, rather than just trying to dive them into a 32 degrees very quickly.
Sure.
The targeted temperature management shows that we're trying, or concept is that you try to get them down to, somewhere between 32 and 36, maintaining sometimes even a near normal body temperature. But the biggest thing is to keep them from becoming febrile. That's another thing that's a goal of the targeted temperature management. So I think that overall, one is therapeutic hypothermia an accepted practice? Absolutely, in the hospital setting. I think the science behind it, again, has been fairly well studied, and that it does reduce the brain metabolic activity. 3, although we've done it in the past, and we've actually done it here in Tuscaloosa with the chill core devices, I don't think that it is as an accepted practice in the pre-hospital arena as it was, let's say, 3, 4, 5 years ago.
Sure.
I think that the research will still continue to evolve from the pre-hospital standpoint, because some people still say, well, you've got to get them to that 32 degrees. We understand that from a pre-hospital standpoint, we're not going to get them to 32 degrees, but if we can take them down a degree en route, not necessarily by chilled saline, but there are other mechanisms, then obviously we've gotten 1 degree closer to our targeted temperature. So I do think that the research will continue to evolve in the pre-hospital arena with therapeutic hypothermia.